Hi guys, hope you're doing great. So good to see you at around the festivals are around the corner. And well, here we are. We'll be doing a quick discussion on the X-ray mini test that was conducted on the app. I think they were fairly straightforward ones, but these are like the starting point for your preparation where you keep on upgrading yourself, and whatever silly mistakes are there, they have to anyway be minimized. So the objective of today's session is just to fine tune those reflexes, and let's get started. So I'll be just waiting for a quick confirmation from your side for the audio and the visual part, and then we can get started for today. Any of your doubts, minor ones, if you have initially, you can come up with that. Hi, Dr. Syed Usman Mari. So good evening, everybody. It's a long tiring day, but at the end of it, like, it's satisfying to interact with the young doctors. And today's the time for those quick x-rays, though nowadays everything in radiology is more focused on investigations like an MRI, but still it's the good old x-ray which will help you in identifying the common problems in the patient. And hi Karan, Kishan, Sujip. So I think we can get started for this session. Let's wait for your interactions at the moment or your responses. Uh, the questions, the clinical findings I've kept minimal in this because I wanted you to interpret the x-rays, and this is what we've given in the app to make it relatively simpler for you guys, where you can notice that this is white, so there would be fluid present, and then there is blunting of the costophrenic angle. You can see that classical Ellis curve which is present here. So yes, guys, I think blunting of the costophrenic angle, cardiophrenic angle, the concavity, the Ellis curve which is present will make the diagnosis very easy for you. That is gonna be pleural effusion, which is answer as A. But I also want you guys to realize the fact that sometimes they might actually try to give you an X-ray in which you might be noticing that there would be a convexity present in case of a concavity. So if you are gonna get an convexity present, then the answer will definitely change, which would be presence of pus in the pleural space. So if it will be the image, the one that I've currently shown before you on the extreme right hand side, then either I can use the word empyema, pranam Anish Karna. So in those circumstances, if there is a convexity present, then the word that I'll be using is empyema, or the word that I'll be using for this would be pyothorax. And then we'll evaluate the patient for whether he's fit at the moment. The pyothorax patient I'm talking about for a thoracocentesis now, because patient could be in sepsis and septic shock as well. So first I'll be like managing the shock component if present, give him empirical antibiotics initially, and then once he's a little better, we can then plan a thoracocentesis and check out the pH and the pleural fluid sugar and the proteins and all those things. So yeah, good evening everybody. I think the answer to this one was easy one, that is option number A, and then the pyothorax part needs to be handled with a bit of care as well. Quick comments in the chat box with respect to what is the preferred vasopressor, though it's a radiology based discussion because I said sepsis, so quick answers for the vasopressor of choice in patients of septic shock. Options are standard ones: dopamine, dobutamine, norepinephrine, phenylephrine. So yes, guys, quickly let me know what vasopressor would you be giving in case a patient with empyema pyothorax is ending up in septic shock, which has a high probability. Yeah, so Rinder was the first one to comment for that one. We'll be using norepinephrine for the patient. So this was like a fairly straightforward one. Just pick up the concavity and the convexity. And though they'll talk about things like split Pura sign and everything, I say that in the exam, you have to be very specific and precise. So if you pick up a concavity, think in terms of hydrothorax. If we pick up a convexity, it would be in empyema. Yes, norepinephrine is the spot on answer. Coming to the second question for today, we have this boy with the pain and swelling around the knee, and then the X-ray is shown. This is the X-ray that is shown, very classical one. I think this session that we are doing for today is having questions which are like just to get you into that drive and into that mode of getting to the spot answers, because some of them are gonna be so simple and straightforward that you'll be wondering, oh man, I was preparing for this. Yeah, I mean, this is gonna be that sunburst appearance, so that would be an osteosarcoma. And anyway, because he was talking about a teenage person and then the swelling around the knee, so that makes it easier. And if it does not say the word crepitus or crackling egg kind of an appearance, doesn't matter. You still know that that sunburst appearance, that classical sunburst is what you see with respect to, and especially the tumor is at the knee joint, that makes it osteosarcoma. For Ewing sarcoma, it would be diaphyseal tumor where that periosteal reaction and the presence of onion peel appearance would be present, though you can't pick up an onion peel very well, but still like the diaphyseal tumor would make it easier. And then you can also see another tumor here, which is like a cotton wool appearance in the bone. So had I given you an x-ray with respect to a cotton wool appearance in the bone, then you would have answered this as a chondrosarcoma. So fairly straightforward ones. The objective of today's session is to, as I said, get the car into a drive. So we are going from first gear, and then obviously we will move on to more technically challenging ones in the forthcoming tests to come. The correct answer for this one is option number A. And as far as the remaining options are concerned, fairly straightforward one. Giant cell tumor will have that classical um, soap bubble appearance present. So yes, you guys comment, soap bubble appearance on the MRI head is the feature of. You get multiple lytic lesions in a soap bubble appearance for giant cell tumor, but soap bubble appearance on an MRI head would be seen in which condition? Yes, guys. Okay, so I think most guys have commented. Maybe I lost the track of the comments in between. When it comes to like a soap bubble appearance on an MRI head, that would be for cryptococcal meningitis. That's usually a AIDS positive patient, and then he's gonna give you low sugar, elevated protein, some amount of lymphocytes. You'll do a CSF ELISA and a India ink, and you'll be able to nail the diagnosis of the patient. Moving to the next one, which is again a straightforward one. Recurrent nasal blockage and then a CT of the paranasal sinuses is given, and I can expect answers from you guys for the same as well. Obviously, doesn't look like a deviated nasal septum, doesn't look like allergic fungal sinusitis. So it's only between the two that you need to work out. Either it's gonna be answered as antroconal polyp or it's going to be concha bullosa. The physical appearance of the two is grossly different. I mean, the image is very straightforward one that you would have read multiple times. Yes, Ravi Kumar, Sayyid Usman, yes, hit the comment button, guys. I mean, this is, should I zoom in? I mean, very easy to pick up. That would be a antroconal polyp. And as far as the image of the second one, which I mentioned, was concha bullosa is concerned, it would be more of like that globular kind of an appearance that would be easily identified. So as such, I can say that this was again a straight pickup. Though the comments were a little slow to come up, the answer for this question is option number B. Yeps. Then is a child with severe anemia undergoes a skull x-ray. So what you will get is a classical hair on end appearance, and that makes it like, though the age group is not given, but still that goes in favor of thalassemia major in a patient. So the correct answer for the current image is option number C. But then I can give you a patient of anemia and I can give you this image. So can you comment on the second image that is given here? Yes, the answer to this one is option number C. But if I change the x-ray, the answer will also change. So I expect you to comment now for the second x-ray. For the first one, it's obviously straightforward thalassemia. You can pick up the classical hair on end appearance. But if I am gonna talk about the second one, then the answers are okay. Multiple myeloma was the first one. Deveshri also mentioned multiple myeloma. You can see the lytic lesions in the skull of the patient. I can pick up question नीट PGS again. यार बच्चों में मल्टीपल माइलोमा तो नहीं होता ना, बच्चों में तो एडल्ट मैन में होता ना मल्टीपल माइलोमा. सो यहाँ पे जो लीजन है, क्या वो रेन ड्रॉप कॉन्फ़िगरेशन है? नहीं है ना, रेन ड्रॉप कॉन्फ़िगरेशन इज नॉट प्रेजेंट हेयर. तो ये जो अपीयरेंस है, दिस लुक्स लाइक अ मैप ऑफ अ कंट्री. So the presentation that I mentioned before you would be called as a geographical skull. And therefore, yeah, I think you guys were able to pick it up immediately. Like, it's not a raindrop configuration, it's a bacha. And then you can see the geographical skull, which makes it easier for you. The answer in those circumstances will turn out to be then histiocytosis X. So for the geographical skull part, as I mentioned, it is LCH, that is Langerhans histiocytosis. Can you tell me the investigational choice for this? For geographical skull, I'll write that again so that the font is appropriate. Yes, guys, what is the investigational choice that you would like to do for this particular patient of Langerhans histiocytosis? He can do a biopsy from the bone itself. No, these are permeating lesions which are present. So you can do a bone biopsy itself, and then you can see, those specifically those big granules can be demonstrated on electron microscopy. So for Langerhans cell histiocytosis, yeah, I mean the markers are there, but yeah, the test that you can do is a bone lesion biopsy that helps us in diagnosis. Can you comment on the investigation for thalassemia major, the investigational choice, please? Quick answers, please. Investigational choice for diagnosis of thalassemia major. Yeah, the markers would be S100, Birbeck granules, the tennis racket appearance would be present. Quick answers, please. Answer for thalassemia major with respect to like what is the investigational choice? Do I need to give prompts for this? I don't think so. Okay, the options are, okay, hemoglobin electrophoresis is coming up as the answer. HPLC, hemoglobin electrophoresis. I think I've explained this to you guys multiple times that for thalassemia, you're not supposed to answer it as thalassemia major or any type of thalassemia. In fact, alpha or beta thalassemia, don't answer hemoglobin electrophoresis. It is gene sequencing, which is the investigational choice. And if gene sequencing is not in the options, then you answer it as high performance liquid chromatography. And if this is not in the options, then you answer it as hemoglobin electrophoresis. So that would be some of the inputs for the images that have been shown. And now you have a patient who came with severe abdominal pain to the emergency room. You can see very classical gas under the diaphragm. So this I don't need to even ask you. I think it's a very straightforward one. The answer would be given as a perforated hollow viscus. That's because of most of the time the person could be having a peptic ulcer disease. He could be having a duodenal ulcer caused by H. pylori, which is the reason for this gas under the diaphragm of the patient. If it was ascites, it would have contributed to elevation of the diaphragm and would have also resulted in, like the X-ray would have been showing the abdominal part as well, very hazy shadow present. For bowel obstruction, there would be multiple air fluid levels present, and volvulus, if it's especially sigmoid volvulus, then that characteristic feature of coffee bean appearance can be present as well. The correct answer for this one on the agenda is option number A. Then is a kid is having vomiting since birth. The mother might be like giving an history of कि बच्चा दूध फेंकता है. That's understandable. Most children can regurgitate feeds as well, but in this case it is vomiting since birth, and that is why like I expect answers from you guys. The question doesn't mention bilious or non-bilious vomiting, right? It's just written vomiting. So it could be regurgitation, it could be congenital hypertrophic pyloric stenosis, it could be a duodenal atresia in a patient as well. Yeah, I mean, you can pick up that double bubble, and that helps me in identifying that what I'm dealing at this particular case would be an abrupt cutoff at this area. So this makes the answer at this would be as a double bubble appearance. The correct answer for this is option number B. Fairly straightforward one. Okay. Then is a 40-year-old patient with fever, night sweats, and a weight loss. And you can see that white shadows in bilateral lung fields. This again is a very typical X-ray that they love to give you. If he had mentioned occupational lung disease, it would have still been easier for me, where I would have thought in terms of silicosis or chickenpox pneumonia. But considering the current representation where this multiple white shadows are present bilaterally, the answer would be given as miliary tuberculosis. Miliary tuberculosis is disseminated tuberculosis where there's a lymphato-hematogenous dissemination happening. For lung abscess, there would always be a presence of a air fluid level. There would be pus settling at the bottom, so that would be a air fluid level for lung abscess. And lung abscess is also one of the very, I would say, causes where fastest clubbing can be seen in a patient. So if the X-ray showed air fluid level, it would have been even much more easier for us to identify. And sarcoidosis anyway ruled out because there is no like big lymph nodes present in the chest of this patient. Then is pain and swelling in the leg of the patient. The X-ray is shown, and if I say anything, the diagnosis will become very obvious. I zoom it slightly so that you can pick up. If I say anything, the diagnosis will become obvious. This is the diaphyseal involvement. So yeah, I mean, one option is I can say or think in terms of osteomyelitis in a patient, but then considering the pain and the swelling and no mention of any fever, the diaphyseal involvement will make it easier for me to identify this. The correct answer for this one, the more appropriate answer for this question that I have currently shown before you would be, because I said the word diaphyseal tumor, which I was trying to avoid and say, the correct answer in this case would be B, that would be a Ewing sarcoma. Then we have a patient who came with chronic cough and he came for evaluation. The X-rays shown but deliberately kept paucity of clinical findings in these because some questions are going to be like straightforward pickup points in a question. Since the question mentions a peculiar radiological finding of chronic cough for evaluation, I think that will make it a little easier for you. Let me zoom into the X-ray as well. So let's look at your interpretations. Okay. Klebsiella pneumoniae will not come with chronic cough. It will have a bulging fissure sign. So that's pretty easy to pick up. I mean, necrotizing pneumonia for Klebsiella pneumoniae, we get a bulging fissure sign. There is pus present in the interlobar fissure. So considering that, it goes more in favor of like, the shadows which would be present in the right upper lobe of the patient goes in favor of like tuberculosis in contrast to histoplasmosis or aspergillosis, for which I would have preferred images from the CT scan only. But from an X-ray, I mean, a common test for chronic cough will think in terms of tuberculosis only. Okay, great. Then is a man who fell in the home and is unable to walk, and you can see a fracture, right? A nasty one. I think it's very much visible. So this person is at risk for development of avascular necrosis. Obviously, it is not the shaft. It's not trochanteric fracture. It is rather a intracapsular fracture of the neck or the femur, and therefore the risk of avascular necrosis in this patient would be dramatically increased. Considering 70-year-old man, can you tell me, like in this patient, if there is a avascular necrosis developing, then what is the treatment that you would be recommending for this patient? Options before you are like open reduction internal fixation. One is we can go in for a hemiarthroplasty, that is the Austin Moore prosthesis, or we can go for a total hip replacement. So quick answers with respect to uh not exactly, man. I mean, when I say the lymphadenopathy, I'll have to go for a common answer, right? That's gonna be like the mediastal adenopathy that is present. I'll think in terms of a more common lesion in the upper lobe. Then I'll think in terms of tuberculosis as compared to that of histoplasmosis. There has to be some kind of immunodeficiency given in the question for me to think in terms of histoplasma. Okay, so yeah, I mean, in this particular case, what we can go in, especially old man is unable to walk, and there would be some component of arthritis present in this patient. So we can go for a THR, that is a total hip replacement. If there was no mention of any like pre-existing arthritis and like the age would have been younger, I could have still thought and gone in for like a hemiarthroplasty in a patient as well. But considering age more than 60 and then avascular necrosis risk, THR would always be recommended. Yep. We have this 3-year-old child presenting with stridor and fever, and the X-ray AP view of the neck is shown. It's so in your face, right? I mean, I would love you guys to hit the comment button here. Hemiarthroplasty is a good answer, Dr. Dinesh, but then the point is, if there is gonna be like pre-existing arthritis is not present in a patient, then Austin Moore prosthesis is fine. But otherwise, like most of the time, because even the other side, the joint space looks to be reduced, so THR and a acetabular reconstruction would be relatively better. Yes, this would be steeple sign. So when I say steeple sign in a patient, that makes it easy. That is Croup, and that would be laryngotracheobronchitis in a patient. The correct answer in this is A. Can you tell me for this guy? It can be a two-step question. He can ask you nebulization with. So can I have answers here? I mean, for this guy, for management purposes, because this is steeple sign, as you can see, like on a church, no, the steeple is present. So for a patient of Croup, like what is the test that you what is the nebulization that you would be doing with? Yeah, we can go it with racemic epinephrine. For laryngotracheobronchitis, it is nebulization with racemic epinephrine, which will reduce the laryngotracheobronchitis component and will help in easing of the airflow obstruction that is occurring in this patient. Yeah. The technical word, I mean, instead of saying adrenaline plane, we'll just refrain from saying that and we'll say the word racemic epinephrine. So easy one here. Okay. A 5-year-old kid, recurrent chest infections. There's a murmur also given, and then he says, "What is the likely diagnosis in this case?" Yeah, okay, so a biphasic stridor would be present. A 5-year-old kid, recurrent infections and a continuous murmur. So then And you can notice that the apex of the heart is shifted downwards and laterally. So this won't be a presentation of tetralogy of Fallot. Tetralogy of Fallot will have a uplifting of the apex. Now उसमें तो जो apex होता है वो uplift हो जाता है. So that is boot-shaped heart. I'll just highlight this once again with two different colors. If it comes to apex of the heart being lifted up, right here, what is happening is using a different color, there is a uh, downwards inferolateral displacement of the heart. That inferolateral means that the left ventricle of the patient is becoming bigger. So this is not a tetralogy of Fallot. You could have easily ruled it out because continuous murmur is given in this question, so it makes it easier for you to identify that continuous murmur would be a feature of patent ductus arteriosus. So the correct answer in this case is option number B. No guys, the answer is not a tetralogy of Fallot. Tetralogy of Fallot का एक्सरे देखेंगे अभी. Tetralogy of Fallot में मैं फिर से बोल रहा हूँ कि क्योंकि राइट वेंट्रिकल का एनलार्जमेंट होता है, तो जो एपेक्स होता है वो अपटर्न हो जाता है. द एपेक्स विल गो अपवर्ड, दैट इज इट विल बी moving right ventricle forms the base of the heart, that is at the diaphragm. So apex is going to be pushed upwards, but when it comes to left ventricular enlargement, the apex is inferior and laterally displaced. So the correct answer in this case is option number B, that would be a patent ductus arteriosus. And even if like he did not mention the murmur, तो आप देखो ना recurrent chest infections लिखा हुआ है. So recurrent chest infections are something that you do not get in a patient of a tetralogy of Fallot. वहाँ पे तो tet spells होते हैं, cyanotic spells present होते हैं. So in patent ductus arteriosus, they would be like recurrent infections because of a pulmonary plethora, or like more blood going into the lungs is the reason why this presentation should be there. So for this one, I think there is absolutely no reason. If the question said a pansystolic murmur, I would have thought of ventricular septal defect. If the question mentioned a mid-diastolic murmur or a ejection systolic murmur with a similar history, I would have answered it as a atrial septal defect. But considering the information, I think you could pick it up as a patent ductus arteriosus. Okay, so the next one is again a spot diagnosis that you can pick up in the case. This would be epiglottitis because you can see that thumb sign present. So the answer in this case is option number C. That's like standard bread and butter questions for you guys. And epiglottitis, laryngotracheobronchitis is what you study in multiple other subjects as well. Okay. Next is a patient with gross abdominal distension. You can see the hostrations. So this is obviously large bowel. You can see a large amount of hostrations present. So this is the large bowel. And yes, guys, is not the small bowel. So I am left with ileus versus toxic megacolon. Ileus will be having dilation of both the small and the large bowel. Like suppose small bowel plus large bowel, both loops would be visible, then I will say it is ileus. But here it is only large bowel, so I'm left with cecal volvulus and toxic megacolon. And the way the transverse colon is going grossly dilated, this looks to be toxic megacolon. And usually that occurs with ulcerative colitis. What is first line management of toxic megacolon? First line management for toxic megacolon, please. Yes, guys. Patient of ulcerative colitis going into toxic megacolon, what would be the initial management that you will be doing? There is no evidence of any perforation. No, if there is a perforation, then it is a separate issue. Otherwise, we will first be giving steroids in the patient. So if he says what is first line management for toxic megacolon and there is no evidence of any perforation present, the first thing that we will do in the patient would be a IV steroids. I repeat that again. We'll do a CT in this patient as well to check for any peritoneal fluid accumulation, which would be occurring due to a perforation, which cannot be detected on an X-ray sometimes. But then if there is no evidence of any peritoneal leak present, then we'll first give steroids in a patient, and only if there's a perforation, then the surgical options would be excluded. I think I've explained this in my medicine discussion in even the rapid revision part, that for toxic megacolon, the initial management would be usage of steroids, and then subsequently it's like an laparoscopic exploration that you would be doing in a patient. This is again a very classical textbook case that he's going to talk about abdominal pain and fever. In these questions, deliberately a paucity of clinical findings have been made because we wanted you to focus on the X-ray images only. So this can be treated as like a spot evaluation that you would like to do. And what you can see is that there would be a step ladder kind of an appearance that is present in this case. Yes, you just took the words out of my mouth. A step ladder word came up initially. That would be a SBO, that is a small bowel obstruction. In case it was paralytic ileus, it would be in a whole bowel dilatation, but at this moment, this would be a SBO, a small bowel Okay, great. This is that boot-shaped heart that you guys were pointing at. So, I mean, you should be able to pick up the displacement of the apex of the heart from the perspective of both left ventricle as well as the right ventricular enlargement. So here it is like the apex of the heart is lifted up, and here you can pick up that boot-shaped heart. So that is okay. And he's mentioned the cyanosis component as well. So it becomes relatively easier for you to pick up the question. But for the previous one that I had shown you, it was a left to right sided one. Okay, so all of us love coffee. And you can see I can call it a bent inner tube, or I can call it a coffee bean as well. So goes more in favor of that bent inner tube kinds. That would be for a case of sigmoid volvulus. Yeah, we will be starting the LRR very soon, and the schedule would be coming. So for those who are preparing for any set, anyway, I've taken a discussion in the app as well. You can look at that. The questions were purely hardcore kinds. The any set one where more than one answer could be correct. But for these, we're keeping them simple at the moment, and that's just to get you into the drive to start doing questions on a regular basis, because it's the match practice that really matters. Because normally we keep on reading theory, but then subsequently it's like the match practice that would ultimately help in achieving good results. Okay guys, so alcoholic came with exertional dyspnea and orthopnea, which are features of heart failure, and you can notice that the cardiothoracic ratio in this patient is increased. Considering that there is a cardiothoracic ratio increment present and alcoholism also given, the diagnosis goes in favor of dilated cardiomyopathy. Alcohol is a good hint in this question. Increased cardiothoracic ratio is also present, plus orthopnea and heart failure findings are also given. Hypertrophic cardiomyopathy, usually 20 to 40 years of age, chest pain symptoms would be given. So that makes it relatively, easy to rule out as well. For restrictive cardiomyopathy and constructive pericarditis, most of the time the cardiothoracic ratio would be normal. Hit the comment button for cardiothoracic ratio more than how much would be considered as significant. Cardiothoracic ratio would be considered as significant as value more than 0.5 for adults and more than 0.6 for children. CT ratio more than 0.5 for adults and more than 0.6 for kids would be considered as significant. And the answer in this particular question would be answered as option number B. भाई इन्हीं सेट का एग्जाम मत दो यार, अगर आप एफएमजी की तैयारी कर रहे हो, जो एफएमजी वाला पेपर है वो दे दो ना. मतलब वाई टू गेट इनटू द हैसल ऑफ डूइंग अ इन्हीं सेट पेपर वेयर मल्टीपल करेक्ट्स आर देयर ना, तो प्रैक्टिस नहीं हो पाती. Okay, guys, so we are coming to the penultimate question here. A 50-year-old woman, she's having breathlessness and she underwent an X-ray. And if I say anything more, then the diagnosis will become much more clearer. So yes, I am so tempted to talk about ECG findings for this one. I'm so tempted to talk about the hemodynamic collapse that can occur in this case. But at this moment, yeah, I need to keep my hypertrophic cardiomyopathy would be having exclusively left. No, on an X-ray, doctor, the cardiothoracic ratio would be increased, but then at the same time, right, there would be no mention of alcoholic. No, then he'll mention an athlete, and then it will describe the symptoms that are present. And more importantly, there would be a not a flabby dilated heart, it would be a left ventricular hypertrophy with the apex being displaced downwards. Like I said, hypertrophy है ना, जब भी लेफ्ट वेंट्रिकल हाइपरट्रॉफी होते हैं तो एपेक्स की inferior displacement होती है. यहाँ पे तो the cardiothoracic ratio was increased, it was like a grossly dilated heart with no significant changes in the position of the apex. So like it's an hypokinetic apex, it's a damaged heart. In hypertrophic cardiomyopathy, it's an inferior lateral displacement that you would be able to pick up in the left ventricle. Okay. Yeah, the money bag appearance is present. Dilated cardiomyopathy, we get a electrical alternance present in this case as well. So the cardiothoracic ratio is very significantly increased. There is electrical alternance that is described as well. There would be low voltage ECG, and then they can go into hemodynamic compromise where the Bextroid component would come in. And then they love to ask about the echocardiographic finding that is called as a diastolic collapse of the ventricles as well. So let's do a quick last one for today. A kid has presented with that breathlessness and hepatomegaly. So both indicates like Breathlessness tells me that the left side of the heart is getting involved. Hepatomegaly is telling me that the right side of the heart is getting involved. So that again is a good hint, because I'm talking about defects where both the left to right and right to left sided shunts can be present. And the moment I say this, I mean, you are, even if you're not able to pick up that figure of 8, it doesn't really matter. What you're able to pick up is that features of left and right both are present. So atrial septal defect is only left to right. Ventricular septal defect is only left to right. Coarctation of aorta is an abnormal. I mean, there's a narrowing, but there would be a 3 sign that would be present here. But then coarctation of aorta mainly presents only with the presence of hypertension. They can be inferior notching of the ribs as well. So considering that we are having a kid, though a little age group is on the higher side, we'll give that answer as that of TAPVC. Yep, that would be figure of 8 or a snowman that would come up. So this would be the last X-ray for today, guys. This was a quick short discussion where we just tried to fine tune your reflexes for today. So if you have, yeah, figure of 3 sign would be present for coarctation, but at the moment what I try to draw is more that snowman or the figure of 8 appearance here, considering the age group of the patient as well. Okay, so we are for the consistency part, yeah, I think the most important thing for anybody to understand at this moment is that because festival time hai, so everybody tends to become a little casual because obviously the celebrations are going on. But at the same time, I mean, you just need to keep the focus on, like, if you're attending live classes, then live or face-to-face classes, then like after attending your coaching, you can still be sitting for 4 hours at least, right? 4 to 5 hours. And in that you can do in that you should first focus on theory, and then like 25 to 25 MCQs in 1 hour are like more than sufficient for you to focus. I mean, that's it. My advice for any set, Gaurav, my advice would be that do check out the LRR series that we conducted for any set. The questions were simulating the actual set variety, the medicine part. Check out how many questions you were able to get correct there, and then you need to check out, I mean, why they went wrong. And most of the time it would be silly mistakes that result in this kind of errors of judgment. Lack of knowledge is a perennial thing in our field, so I hope we can be able to work it out later. No, Dr. Pranav, please check out the Iniset one, and there you will be able to realize the differences. So this was just a confidence building measure that we're trying to do at the moment. Yeah, Diveshri, you are perfectly right. This would be a yes. Uh, okay, X-rays given. Yeah, you're right. This would not be dilated cardiomyopathy, pericardial effusion. Yeah, that's why I brought the screen up. This would be pericardial effusion. The cardiothoracic ratio is increased. That's why saying the word electrical alternance. And I was saying like the patient can develop a hemodynamic compromise and then can end up with the diastolic collapse of the ventricles as well. So we are sorted for today. Yeah, Deveshri, perfectly right. So thank you so much for joining in this session. And we'll keep on coming with this short series on a recurrent basis. The next one is based on instruments. The subsequents would be ECG based as well. So I'm gonna see you again multiple times this month, so that I can guide you to my best optimal capacity for achieving the desired success, or as we say, the coveted rank that you are trying for. So thank you so much, guys. Take care. God bless you.